All right, recording is live. So we are back. We are episode 6 of 7. Yeah, count them.
Count them out. 6, baby.
We're on a roll now. So what's going on, Dr. V? You're back on the horse this week, which is pretty cool.
Practice is back open, seeing patients on a very, very limited basis, trying to keep everything as controlled and I guess orderly as possible. I got a 5-patient limit per day. I'm 3 hours a day, 1 new patient limit a day, and cleaning everything, showing off all my PPE, and yeah, it's just good to be back on the wagon. You know what I mean?
I do, yeah. I saw you dressed up there like a Starship Trooper. It was looking awesome. Yeah. What's it like?
Ahead.
What's it like treating in all the gear? Because that's not something I've experienced. What's it like?
I mean, I would be very, very dishonest if I told you that that's how I treated every individual.
Right.
An opportunity was presented to me to obtain some of that PPE for the 5-finger discount. Christine, if you're listening, thank you very, very much. I appreciate everything you do for me. But it's more of like a by feel basis with the patient. So it's like, to me, I have no fear whatsoever of catching this thing. If it happens, it happens. I shut down. I'm sorry. Whatever. I don't know if this is going to be a bad podcast already. People are going to be polarized about it. But, you know, there's an inherent risk, or there's more of an inherent risk for certain individuals, depending on where they live, depending on their age, depending on everything like that. So I'm PPE on kind of a case-by-case basis. I'm always going to default to it. And if someone's like, yeah, I don't want to wear this shit, I'm like, all right, whatever. I don't really give a flying hoot. Like, if my mask is on, then do whatever the hell you want, because theoretically I'm protected, right? That's what they want you to believe.
Have they put regulations on what you have to actually do? Because we don't have a lot of guidelines, I guess.
It's wear a mask in public. The nature of how the job is set up for you and I is not conducive to a ton of PPE. First of all, the sterility of the PPE is exactly the opposite of why people enjoy going to musculoskeletal healthcare practitioners, especially you and I. So it's like, this is a weird concept, but the notion that you can put your hands on somebody in an appropriate way with the informed consent signed, all this other shit, and that contact in itself is a healing mechanism outside of what you're doing to actually reduce an adhesion or improve range of motion. So it's like, I'm trying to preserve a little bit of that because that's what makes it magic. And then I've done a little bit of treatment with like nitrile gloves on.
It's hard,
it
right?
Sort of works. It sort of doesn't. I don't get that feedback on my fingers quite as much as I do without it. But if it's like a thing where someone's like, yeah, I want you to wear gloves, I'll just go with a little less feedback and see what happens. And then we're so up here and everybody's so down here, right? Because that's our leverage point. So it's like, if you got a mask up in through here, it's hard to see. So not super conducive for PPE. And then don't even get me started with the face shield. The face shield's crazy, man. You take one breath and then it fogs up the whole face shield and you can't even see anything. So it's going to be a process to get up and running again. And I don't know. I think until people generally start to feel more comfortable leaving their houses, it's going to be slow. With that being said, that one time you leave the house and you come to my office, I want it to be the absolute best experience that you could possibly have in a post-lockdown world. So that's what I'm trying to do. Every time you walk into my office, I want it to be the most fulfilling 20 minutes possible, because that may be the first time that you've been out and actually in contact with another human being. So, I mean, I've been getting good feedback. I've been having a blast. I've been coming home, you know, like it's a freaking Willy Wonka on the Chocolate Factory movie, like singing and running all over the place, feel Humphrey Bogart at my ass. And yeah, it's just good to have a purpose again.
Yeah, I mean, it reaffirms that you're doing the right thing with your life because you're doing something that you're really excited to get back to. So that's, how good's that?
And from a financial standpoint, it's like I'm just at the point where I'm trying to break even because I enjoy doing it. Yeah. Like I have other jobs, I have other means of making money. I'm writing a book, it's fun when you don't need to do it. And it's like, listen, I'm just trying to make sure that I save enough money to go to a seminar every couple of weeks or every couple of months. I make my rent, I pay my malpractice insurance, everything gets done. And it's like anything after that is gravy. And it's the most liberating feeling you could possibly imagine.
Yeah, I think the litmus test is really, if you were asked, what would you do tomorrow if you won the lotto today? So if you became extremely wealthy overnight, would you still be showing up to do the same thing tomorrow?
Yeah, I would be more selective with who I say yes to from a patient-based standpoint. Like I'd be so quick to be like, I can't help you. Sorry. Here's my colleague down the road. Like bad patients are bad patients and bad individuals are bad individuals and shitty humans are shitty humans. So I would have like absolutely zero tolerance for helping anybody that, not that I didn't respect, but I didn't find any redeeming qualities in. I'd be like, yeah, sorry, there's a guy down the road that he does the same thing and yada, yada. But like my friends, my family, those who really, really need my help, gosh, I'd do it for free if I could. I really, really would. And coming from me, who is like the world's most, we're being real controversial right now, but I'm like the world's most pure, laissez-faire capitalist on the entire planet. It's like, I give you service, you give me money, my service better, your money more, like game over. I'd do it for free, without a doubt.
Yeah, I didn't used to be able to say that. I definitely can now. I used to think, I remember sort of getting posed that question when I used to work in a corporate environment, and I sort of pictured myself being a bit more like Ari Gold, walking in with the paintball gun and just telling everyone to get fucked and annihilating them with paintballs. So that was where it was time for me to get out of that space, really.
It's tough when you're making other people rich.
All right.
It's real tough, especially when you think about it, you're like, I don't know, I did all this shit. I worked 40 hours a week. I got myself my bi-weekly paycheck. And it's like, whatever. But it's like when it's for you, or when you're building a skill, or you're not doing it just because of a paycheck, your whole world opens up. You're like, this is what purpose feels like. You literally have that aha moment. You're like, this is why I'm on this earth. And as long as I'm pursuing this, doesn't matter if you're living in your in-laws' guest bedroom like me, doesn't matter what you're doing, you have that purpose, then, and we're getting metaphysical, then that direction will lead to so much happiness and so much satisfaction. So I'm a big believer that you got to go out and at least try it once, try working for yourself, see if you have it in you. Most people don't even think that they have it in them, excuse me. Don't, but that, I was going to say, don't put it in me, but you don't know you have it until you try it, if that makes sense. You're like, oh, I'm very, very comfortable with my security and my 401k, and I'm going to put a little bit in the stock market and in my savings account, and I've got an emergency fund and all this other stuff. But it's like, you don't know who you are until you're like, fuck, how am I going to eat? Like, my hands are literally going to feed me this month based on how well I can remove your adhesion, improve your joint health, and how much you talk to your friends about me. So it's like, you're going to bet on yourself? Some Michael Jordan shit right there.
Yeah, I had no idea that I actually found that kind of interesting personally, that I wanted to kind of take that route. And it wasn't until, I hadn't really thought about it if it was something that I was going to vibe with until I'd already pushed the button. And then I think you just kind of roll with it. But for me, it's the whole idea of developing something that you kind of do in your way. I don't know. if that kind of makes me sound like an asshole, I felt that way a few times, because it's kind of like, I'm going to do it my way, and that's my way, and that's just it.
Right.
But I love that. I love that autonomy and being able to try ideas, and you know, some things work, some things don't. You learn some lessons along the way, but it's pretty cool just being able to have the groundwork to be able to try some of those things, you know.
It's nice. It's a liberating feeling.
It is.
Freedom, right? We're all about freedom. Australians and Americans all about freedom.
100%. So we are week 6 out of 7. We've been plugging away at this thing. I think the thing that stands out now the most for me is that we've covered a lot of ground in getting through 7 weeks, where we're at week 6, and now we're starting to talk about treatment. So all of these principles are feeding into what drives practice for us. And after 5 weeks, 6 weeks, we're finally going to get into the weeds a bit more on treatment. So I think that's an important point, because there's so much that comes before that, or that is front loaded before getting to treatment. And that's not always the way in every setting, but it's an important point to actually go through those things to get to the treatment that is the right treatment. Is that been your experience always as you sort of come through? Is that the balance of these things has been the right way or the wrong way, or what have you seen leading up to this point now?
You know, at the beginning of my practice, not even the beginning of my practicing career, not necessarily my practice per se. I did not focus as much on the stuff that was, I guess, closer to the foundation of this pyramid, right? I always think of it like this pyramid, and at the very tip top is like the fun shit that you can do. And to me, the fun shit is like treatment. Wow, your hand got here, now it gets here. I'm the fucking best. So yeah, you want to, when you're a little bit less mature as a practitioner, you want to get to that point, because that's like that dopamine rush for you, right? That's the chase. That's the, you know, it's the chocolate chip cookie. So it took me a long time to just slow down and relax and just develop a greater acumen of what's going on in the human body, right? Taking a really, really quality history, taking time in between the history and the exam, even if it's 30 seconds on my own, to be like, this is what I think is going on. And the more you do that, the better off you're going to be from a diagnostic standpoint. Then you go into that exam and you confirm that exam with the diagnosis. And as long as you approach it in that linear fashion, it's going to make that cherry on top so much sweeter. And then it improves kind of your swagger as a practitioner as well. Because now I can take a history on somebody and be like, you know, when certain bells go off in my head, I'll straight up tell them. I'll be like, I'm 85% sure that I know exactly what's going on. Let's slow down. I need to take an exam just to confirm. And then boom, you take the exam and you go, yeah, just what I thought. I fix this all the time. This is something that's easy for me. It's going to take time, but let's work a little magic here and let's get it done. So you almost have to take a sick appreciation of the little things that you have to do before you start treating, so you can get good at those little things, so then you can do a better job of treating down the road, right? It's kind of like that, you know, the treatment is the CrossFit competition, it's the race. But if you don't develop a sick appreciation with a 30-minute chipper, or, you know, 30 on, 30 off on the air bike, or boring technique work in the gymnastics realm, you're not going to do well on that competition. And then it doesn't matter how many times you can compete. You're like, oh, I'm going to compete fucking 500 times this week. Doesn't matter. You're going to suck now 500 times. So it takes some patience. It takes a little bit of trusting the process, but man, once you get it, and once you do 2 passes on somebody's infraspinatus and you get an 8% improvement to their shoulder function, you're like, yeah, I know what I'm doing. I need you this many times. No questions asked. I'll tell you when you're done. We'll both know when we're done. And this is how much it's going to cost.
We keep being able to draw some nice comparisons to the CrossFit realm, which I think is pretty cool.
You can do running too, like a 5K. It's like, yeah, you want to go race 5Ks, but unless you go do your 400 meters of lunges and your tempo work and your long, slow distance and your sprint stuff, it's going to suck. Studying for a test. The exam, Chris, you know what's going on. If you don't develop a sick appreciation for obtaining as much relevant knowledge as you can from studying a course, then you're not going to do well on the test. So it's life. It's literally an analogy for life.
Yeah.
And appreciate the small, boring stuff.
It's the importance of all those factors as well, because if the time hasn't been put into developing the treatment skill as well, then if that's not done well, then the rest of it hasn't really mattered as much either, because you're still not achieving anything. So everything's got to be done in balance, right?
You're like that person that's like a practice hero. You ever remember like a practice hero in sports or rugby or anything like that, where they're like really, really good in practice, but they haven't developed the mental acumen to actually execute in the actual event. We used to call them in baseball BP heroes. So we'd be taking batting practice before the game, and they'd be freaking hitting home runs left and right. Then all of a sudden the game would come, and their mind would prevent them from actually using the skills that they learn, or using, the fruits of their labor. And they'd go 0 for 4, strike out 4 times, and they'd be in a pissy mood on the bus home.
Yeah, like to come back to the CrossFit comparisons again, this is going way back, but it's kind of an interesting point. I think one of the things that I actually carried over from when I used to do some CrossFit work, I used to work in my mate's gym. We used to run some classes, and then I did a bit of that there with him for a couple of years, and that was very early on in my studies and everything like that. But I remember when I first started doing that, I was pretty crap at it, because, actually standing in front of a group and actually giving instruction to a group. And, it's one of those things that you just think that's going to be easy. I know how to work out. It's, but then you actually get put in that scenario and you actually do it, and it's not what you thought it was going to be. It's so much harder, and it is a skill. And it's one of those things that develops with repetitions and with time, and confidence gets built. And it does get better, and you get better at it. And eventually you don't think about it anymore. You don't put as much time into planning the class. You don't have to think about it as much. It just becomes more of a natural skill. And I actually found that having that under my belt carried over quite significantly into clinical interactions, and just having the confidence to sit down with someone and really own that interaction, and really be able to drive that, and have the confidence to give direction and that sort of thing. For me, that was huge, and it really stood out, I think, very early, because I could sort of see some other people that was the first time that they had to do that sort of thing. And I remember feeling what that was like, and it was hard. So there you go. A little bit of carryover from CrossFit, but yeah, man. Did you sort of experience that as well?
Oh gosh. Yeah. I mean, two stories that kind of, I guess, align with what's going on. When I was in school, I didn't do any extracurricular. I didn't do any after school club. I wasn't in the sports rehab program. I wasn't in motion palpation club. I wasn't doing applied kinesiology, any shit like that. What I did was I got a job at the local CrossFit box. And the skills that I developed at that local CrossFit box were far more than what anybody developed in motion palpation club, what anybody developed in, of course, applied kinesiology. But that was my huge takeaway. I didn't graduate with honors. But by the time I graduated, I had interacted with 1,000 people who were interested in me improving their health. And yeah, we'll just stick with that. The other story, I don't know if it's relevant. Weightlifting is the perfect sport. Olympic weightlifting is the perfect sport that separates the competition from the actual, I guess, practice, because the weights always weigh the same, right? So I used to love walking into a meet, seeing the list of people, and you already know what people's PRs are, right? Because the federation is listing, okay, this person's clean and jerk is 120 kilos, this person is snatch 100 kilos. So I'd look and I'd say, oh, I'm like 6 from the top. How the fuck am I going to podium today? Like, how am I going to get on? I've got a game. I've got to execute the actual competition event better than 3 people in order to get them to fuck up so that I could bring home a little piece of cheap bronze. So that was one of the things that I loved about weightlifting, is that you could outperform people's expectations based on how you executed on game day without anybody actively getting in your way, if that makes sense. So it's like no one's trying to run you over like in rugby. No one's designed to play to cancel you out. It's like 120 kilos is 120 kilos. Nobody turns gravity up. How are you going to make yourself stronger relative to this group? So that was just one interesting thing that I thought, based on the not undervaluing, valuing points 1 through 5, but not undervaluing then the diagnosis part.
It's all between the ears, right?
That's the best part. It's the most fun you can have, without a doubt.
So if we followed all of these steps, we've considered load versus capacity, we've considered the pathology that is involved, we've considered the symptoms, we've done all of that data collection, we've measured everything, so we've got a very complete history, arrive at a conclusion, a diagnosis. So based on that, then we have a treatment plan. We have things that we're going to treat. So let's say with our diagnosis, we might have a number of things in there that are going to correlate to functional tests, for instance. So you might have identified for someone that they've got a very limited lumbar flexion, so their lower back's not flexing well. They might also have a very short straight leg raise, and let's throw in a supine hip flexion or something like that. But on that list, we're going to pick out the top thing, the biggest thing. So let's say that's the lumbar flexion, because that's, in low back cases, that's going to be top of the list for most people. Why do we often just focus on fixing that first? So if we go for the worst thing and we focus on that, why? Because that might seem strange to some people sometimes if they go, well, I got 3 things that are wrong here, and why aren't we blasting through all 3 of them? Why do we sort of have a focus on fixing something first?
Well, it's not 100% of the time. How do I put this? So you've got low back pain, or say we test 5 tests and you've got low back pain, but something like your supine hip flexion is 50% or 60%, but your lumbopelvic flexion is 70%. So for me, even though your hip flexion is 70%, your hip flexion is worse than your lower back flexion, I still may go in, depending on how bad that lower back is, how easy I think I can fix it. And I might go fix the one that's not the actual worst test. Now, this happens very, very rarely, but it's not a cut and dry for me thing where it's like fix worst test first, fix pain first, right? So you have to then correlate the functional, I guess, outcomes of the tests back into the diagnosis. So it's like your chief complaint, your diagnosis is a lumbar disc injury, and you've got a 70% lumbar back and a 60% hip. I'm still probably going to go into that 70% lower back and try and get that fixed first, because you may experience then a greater change in symptoms earlier in the treatment plan. Does that happen often? No. Oftentimes we just go in and the worst test absolutely always correlates with the symptom set and the diagnosis, and we go and we fix that because that's where our greatest area of opportunity is. That's where we're going to induce the highest level of change so that you feel the least amount of symptoms moving forward. And then I've got you bought in, right? So you're not feeling lower back symptoms. I've got you bought in. I told you what was going to happen. I predicted it. And now I'm saying, listen, we got your back all fixed. Now what I have to do is go in, fix your posterior, your hip, your hamstring and your sciatic nerve so that you don't then redevelop adhesion in the lower back. So you stay out of my office forever. So sometimes it's a compliance thing. I hope that answers your question.
Yeah, I think so. Yeah, I think we're getting there.
I never know because I start going off on tangents.
Yeah, look, what I'm trying to steer it around a little bit to give the listeners an idea about why this is different. Like, what makes this unique? So maybe let's steer it down the path of the actual treatment itself, because we've sort of talked about the application and the scenarios and the situations that we apply this in, but the actual treatment itself is, I think, unique. And certainly if we're talking about treating the lower back, for instance, so the actual treatment of lumbar erectors, I haven't seen that done this way anywhere else. And so, and I think it can also be a little bit imposing sometimes when you show someone, we're going to use this lumbar flexion table. You're going to be on your hands and knees essentially, and I'm going to be standing behind you. That's an interesting position to be in. So that needs to be explained well. But there's a very good reason for this, right? Because that's the best mechanical position to achieve what we need to achieve. But the whole idea of treating fibrosis or adhesion, I don't think it's, I mean, I could be wrong, but I don't think it's very popular. It's not something that I sort of became aware of really at all until I actually took an active release techniques course years ago. And that kind of opened up this whole sphere of treating these kind of problems. And, the idea of a nerve entrapment, that was brand new to me at that stage. I hadn't really heard of that before, but I mean, how big of a, how common of a problem is that? So these things are very, very common, very widespread, yet it's not very popular or very well known. So I think that's something that we should talk about a little bit, because it is one of the things that sets us apart in the market, and it's a very important point.
Yeah, I mean, the simplest way to describe it is we don't do anything that doesn't give you permanent change to your functional tests, period. So if a lower back manipulation would improve your quadruped lumbar flexion, would improve your lower back capacity over the course of the long term, we would do it. It doesn't. McKinsey doesn't. The only thing that does is the only thing that we focused so much of our time at to improve. And that's largely, 75 to 80% removing adhesion, 20% prescribing very, very basic rehabilitation exercises. So that's what separates us, is that we're chiropractors that don't do chiropractic manipulation. And it's not because we have anything against it from a philosophical standpoint. It's because we don't feel like it delivers permanent results over the course of months and even years, right? We fix people and they have their results hold for literally years at a time. So that's what truly, truly separates us. The fact that, hey, we're not doing anything to bill your insurance up. We're not doing anything to make you feel good temporarily. We're only doing what's absolutely necessary over the course of a visit in order to improve your function and to fix you permanently. So, is it Are we removing adhesion with an instrument? Are we removing adhesion with our hands? Does it matter what we do? No, as long as it removes the adhesion and as long as it improves your function, that's all we care about. Now, does a tool lend itself better to certain areas than your hands? 100%. It's just like natural physics and geometry of the human body. I would treat everything with a tool if I could, but there's just certain things that we can't get to with a tool, and a thumb is better equipped. And don't get any weird ideas of Logan Basic technique. The thumb is the best equipped to handle certain spots.
Yeah, and the idea of permanent relief is it depends on the load versus capacity, right? Because you can get an amazing result for someone and have them walk out of clinic and their function's excellent, but if they go straight back into the same environment with the same amount of load as before or whatever got them to that point, then there can be a redevelopment of that problem, right? And that's going to vary for everyone. So it's not necessarily a magic. I mean, sometimes it feels like it's, if you unadhere something that's kind of stuck, you get an amazing result. It can feel like magic, but it's not that. It's
when it feels like magic, it's because we've spent so much time on those first 5 steps that we know exactly where to go. We've honed our treatment skills, and yeah, you've never experienced something like that. So of course you're going to be like, holy shit, right? It's not Lord of the Rings or World of Warcraft or anything like that. It's just the function of an expert who's taken the time to hone every bit of his skills or her skills, excuse me. Sorry, BuzzFeed. And yeah, because of that, what is seemingly difficult to the patient, they're not perceiving all the hours and all the time and all the money that we've spent before they came in order to get them those results that quickly.
Yeah, I had an experience with that this week, actually. I hadn't had any treatment myself for quite a while, which is pretty bad. We're kind of the ones that should be looking after our bodies the most, and we probably do it the least. So I finally made some time to go and see Dr. Marcus at Bondi Junction, and he'd been out of practice for a couple of weeks, but he was back. And so I went straight in to see him, which was awesome because I hadn't done that for a while. And, my lower back, it just needed it big time. I'd really been feeling this whole sort of quarantine thing, like I think most people are. It just felt good. He found what needed to be treated through palpation, and he was actually able to get down into a capsule, my L45 capsule, and standing up after that and actually, retesting the lumbar flexion, everything, man, it's hard to kind of put really descriptive words around what that feels like. And so it makes me have an appreciation for how hard it is sometimes for patients to put words around what they're trying to describe to you, because it doesn't always lend itself well to very descriptive terms. But it is a very nice feeling when you can sort of feel that motion is coming back. It's a really good thing. So for him, that was an easy thing to do. The specificity was there. He knew what he felt. He knew how to treat it. He knew how to generate the right amount of tension and how to guide me to work with him to create that as well. So when all that comes together, we didn't have to spend a lot of time on that because it was just very precise and done very well.
It's a beautiful thing. It's an absolute beautiful thing. And the best part is that when you're good at the treatment, we can go back and we can test what we've tested, and you will see a measurable improvement instantly. And that a good percentage of that measurable improvement that came instantly will last until your next appointment. So that's really how we know that we've induced change. Anybody can get change induced in an individual in the short term. You can use, you can play with the neurology of the human body. Go ahead, do a little stretching before CrossFit, touch your toes, you're going to have better range of motion. But now the next time you go to touch your toes 4, 6, 7, 8 hours later, you're not going to have it. So the true sign of expert treatment is you hold on to a certain percentage of that range of motion from the beginning of one visit to the beginning of the next visit.
That sort of brings up like the 3 pillars of what good treatment should be, right? So number 1, it should be safe. Number 2, it should be effective. And number 3, it should be durable. It should last, or at least a good portion of it should last, as you mentioned, because we're probably always going to catch some sort of reflex change. So some part of the nervous system is going to get stimulated a little bit, but we want a good portion of that to be lasting change. So that's, if we go back through these 3 things, it has to be safe, right? I can't really think of anything in the treatment that we do that has questions about whether it is safe.
Be a little sore the next day sometimes.
At worst, and potentially some people may get a little bit of bruising. We're all a little bit different with how we react in that way. But that should be the worst outcome. I've always struggled a little bit with the fact that, manipulations of the neck, for instance, there's a lot of literature around that as to why it is or potentially isn't safe, or what the risks are. And so there's a lot out there to read about, and depending on who wrote it, whether it's sort of positive or negative, I guess. But the thing that I kind of find difficult about that is, if there's really a question around that, then how comfortable should we be? I guess it's an acceptable risk thing, right? But I don't know. I've just never been able to get really comfortable with that. I don't know.
Especially when you compare it to the relative risk of anything that we do. Like, okay, maybe the risk of something happening in a cervical manipulation is, 0.1%. You then look at that and you compare it to what the risk of what we do is. Gosh, it's 0.001% of anything going wrong. And by anything going wrong, again, something serious. So in the grand scheme of medicine, the chiropractic manipulation may not be that risky, and you can usually judge a profession's risk by the amount that they're paying in malpractice premiums. But ours, compared to a chiropractic manipulation, there's not even a measurable risk. I can't think of one thing that I've actually ever done to a patient where they're like, yeah, like, you did this to me. I'm like, oh, no, I can't think of one time. I've been wrong, right? I've messed up. I've treated things and it hasn't helped, but I can't think of any time that I've hurt somebody.
Yeah. Look, a bruise for a couple of days is not a stroke, I suppose.
Right.
So,
no, really? It's not?
Yeah.
Okay.
Yeah.
Okay. I'll have to write the American Chiropractic Association.
Yeah. Look, I think the argument is that I've seen is that where a manipulation has been blamed for a stroke, it's because that patient was already in the process of having that stroke when they came in. I don't know, chicken or the egg sort of thing. But yeah, look, I mean, I'm not by any means trying to get controversial or shit on anything, but my sort of, and this could be just a very basic way of thinking, and maybe that speaks to my intelligence, I don't know, but I sort of think of, so if a manipulation is correcting joint dysfunction, right? So essentially you're doing that because that joint is not moving in a certain plane. So my thinking around that is, well, if the tissues that hang off that joint, that allow that joint to move, that need to be able to do their job for that joint to move in the planes that it needs to, They need to be able to lengthen. They need to be able to contract. They need to be able to do the things that they need to do properly. If they're healthy, if they're in a good state, if they're able to do that functional work, then does that joint actually end up being stuck? I don't know. I don't know if anyone knows that, but it makes.
I'll postulate no.
Yeah.
I mean, the name of joint health still is, without a doubt, joint centration, right? If that joint is centered, right, the bone is centered into the socket, you will not get joint pain. The question becomes, what is your mechanism to center that joint, and does it provide long-lasting relief? So it's like, theoretically, if a chiropractor's main job is to center a joint, then yeah, we're still very much chiropractors. It's just the mechanism at which you go about that. So if you look at the two reasons that could potentially cause a lack of joint centration, we'll just use that for simplicity's sake. It's either going to be length, strength, or degeneration. Degeneration, nobody's going to fix. Length is going to be caused by adhesion or protective tension. Strength is something that is obvious, right? If you're putting up a tent and you're kind of trying to stick that pole into the ground and you want it to go straight up, then you bet your ass that you want to have two poles pulling on that tent, that center pole. I don't know. I don't fucking go camping, that are the same length, that are the same level of tension. You put one shorter than the other, it's going to tip. You put one stronger than the other, it's going to tip. So strength and length are the two main mechanisms that we possess in order to center the joint. Now, a chiropractor can go in there and they can manipulate that joint, and I can blast it with proprioceptive feedback to put it into place temporarily. But 20 minutes later, back out of place. So we're trying to accomplish the same thing, just one's more effective than the other in the long term. So one does a better job at attacking those last two tenets, which is effectiveness, efficacy, and durability.
Yeah, it's like the guide wires on a ship or something, right? That are
a bridge. Yeah, same thing.
Yeah, exactly. Trying to support things and keep it centered. So if you've got one that's got more tension or one that's short, everything's going to kind of tilt in that direction, that sort of thing, right? So it's restoring that through, and that, I mean, that's what hopefully that's what we identify through our, functional assessment and through palpation and that sort of thing. So if you go kind of right for it'd be like adjusting the length of the sailing ship mast or something and trying to make it longer or shorter to adjust for the pitch. Mm-hmm. Rather than actually just tightening up the guide wire or lengthening the guide wire or whatever that is. I guess that's the best analogy I can think of.
Yeah, it's simple. You have a flagpole. You're going to try to push the flagpole to temporarily, change the length of the guide wire. Or you want to take the guide wire and just make it fucking longer forever, so that you never have to do that. I mean, it's a beautiful little business model, and I'll get controversial right now. I don't care. It's 5:00 on a Friday and I'm ready to rock and roll. But do I think that most of them genuinely believe that they're helping you? 1,000%. Do I think they understand that the mechanism in which they're using isn't as permanent as they're making you believe? 100%. I mean, yeah, I'd love to see you 3 times a week for 3 years. I'd be rich, right? I'd love to I wouldn't love this, but I'd love to see you 3 times a week for 3 years at 3 minutes an appointment. Because then I can see 100 of you a day, and I can see 1,000 of you a week or 700 of you a week, and I'm going to bill your insurance company and they're not going to say a damn word. So it's a temporary intervention to a chronic issue. You're attacking the secondary, right? The primary is the adhesion and the muscle tissue dysfunction. The secondary is the actual joint centration. By attacking the secondary, you don't worry about the primary, and the primary then just recapitulates to more secondaries.
So this might be an interesting point for someone who maybe does get adjusted for a same problem on a regular basis. There's, depending who you speak to, you might hear of someone that goes, my hips are always going out, or, that's just something that you hear pretty commonly, right? But, and it needs an adjustment to whack it back in, sort of thing. But so if you think about that a little bit more laterally, yes, maybe that joint is not working properly. Maybe there's some motion missing from it, but why? Like, why does that continually keep happening? So if there's a leverage issue in terms of the tissues around that, then that's where we need to be looking. So
yeah, I love when people tell me that their hips go out of whack, because it's such an easy fix. And you look like a miracle worker. It's like, yeah, one side of my pelvis is higher than the other. Well, maybe that side of your lumbar erectors are shorter than the other side, and it's causing. So if I go ahead and treat the lumbar erectors on this side, what you're going to find is now it goes back down to, oh, wow, I'm even, and I don't need to see you once a week for the rest of my life. Or I could use a drop table and just bam, 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 wham, jam, pi, ilium, boom, once a week forever. So it's easy. I love when I hear that, because I'm like, oh, well, I'm going to fix you and you're never going to need me again.
Yeah, I think treatment of the lumbar erectors, when done well, has to be one of the most revolutionary things for mankind in a modern society. Because up until I've learned how to do this work that we can do now and actually understand how it needs to flex and be able to measure that, treatment of lumbar erectors consisted of like compression, jamming the end of your elbow across someone's erectors, or I don't know, whacking them into a flexion adjustment or something to encourage flexion, or releasing the QL because there's tension there, or you know what I mean? Like it's really just kind of reflexive work throughout that area.
Until you can get the inflammation to go down, say you fix them, and then 2 months later they're back in.
Yeah, for me, it's very exciting, I think, when you've been able to spend a bit of time with someone that has a really poor lumbar flexion and you've palpated that from day one. And it feels like, it's sort of the way I kind of try and explain it to someone is that it feels like a really overcooked steak. Like, it doesn't compress well. It's not like a nice, fresh, lean cut of meat that's very soft. And you feel that progression happen, and sometimes it takes a bit longer in some people. Other people respond a lot quicker. Maybe that's on me, I don't know, but there seems to be a little bit of variation there. But man, when you actually get that and you feel that change, it's amazing. And there's no other way, and trust me, I've tried a lot of them, to be able to restore that. And it always correlates with someone feeling better. Shocker, right? Yeah. So I think, I think that for me, with the amount of back pain that we know about in the world, that for me is, I think, one of the biggest gifts that's been given to musculoskeletal healthcare, is being able to treat that effectively, because it can really turn around. If that's the one thing that you can turn around for someone, it can make a huge difference in their life.
Especially if you can. Everybody has back pain. So sometimes because everybody has back pain, they're just like, well, this is just going to be a part of my life. If you can destigmatize back pain as something that you don't have to have, you can change the world by fixing 5 to 10 people's backs a week. That's it. You will literally change the outlook of the world by fixing people's lower backs. You just get your message across that having low back pain is not something that you need to have. Fix a couple people, have them tell their friends. But once you get to that point, the world is your oyster. You could make a lot of money you can make a comfortable living for you and your offspring for many years to come by being ridiculously good at just treating lower back pain. And I'm not even talking about hips. You could literally be a lumbar erector, capsule, supraspinatus, specialist. That's it. You'd fucking kill it. Put yourself in New York City, charge $4,000 to fix people's lower back, and congratulations. It's kind of like what somebody you know is doing.
I love that idea. Yeah, no, it is a huge problem. I ran into the non-specific low back pain idea again this week, and I know I beat on this drum, and it's a point that I keep bringing up, but I just fucking hate it. So I'm going to keep beating on this drum, and if I'm wrong, I'm wrong. I don't care. Whether or not, I hate this idea of non-specific low back pain, and to be able to say that that's what someone has, it kills me. But even if I'm not perfect in identifying exactly what is wrong, if it's not 100% right, at least the intention is there, and it's going to be a fuckload closer than saying it is non-specific. And I heard this twice during the week, at least twice, that this pain referral pattern is just non-specific low back pain. Fuck off. Can I say that any clearer?
It's laziness, man. You literally didn't read fucking Netters. The most basic illustrated anatomical guide ever compiled in the history of mankind has these pain referral patterns very specifically listed. There's no excuse. And it's like, you ever seen The Patriot with Heath Ledger and Mel Gibson?
I love that movie. Yes.
He's a good Aussie, right? Mel Gibson? Is he Australian?
He's a bit of a nut job. So he's done some pretty crazy shit, like alcoholism and racism, and he's been way out there, but he's made some killer movies.
But is he Australian?
Yeah, he is.
Yes.
Yeah.
All right. So one of the things I always think about is when he's teaching Heath Ledger to shoot. Aim small, miss small. So because you have an actual idea of what could be going on, you're aiming small. Your specificity of your diagnosis is so high that your bullseye is small. So you're aiming for this bullseye. What are you going to do? You're going to hit here? You're still going to be pretty fucking close. Do you want to hit the bullseye every time? Absolutely. Will you fix more people hitting the bullseye every time? Absolutely. But you're going to fix so many more people than the average practitioner by missing a small target. So I always think of that once a day. Once a day, I think of Mel Gibson.
Yeah, we love Mel Gibson. Maybe we'll get him on the podcast.
Let's try. Let's call up Mel. He was just on Joe Rogan, wasn't he? He'll come over to us. Hey, Mel.
Rogan's a ball brother, so he might be sympathetic.
Rogan's a ball brother. Let's just go straight to Joe Rogan. Let's just get him on our pod.
We're all on Spotify now,
We're all on Spotify.
We're making 5 cents. 5 cents an episode. He's got $100 million contract, but we're closing the gap.
Past 2 episodes, but get him on. Be 3 bald bastards. I'll get a full sleeve tattoo. We'll smoke pot. Actually, no, that's bad. Don't smoke pot. Sorry, Dad. And we'll enjoy it. 3 bald bastards. Episode 1. Introducing our new co-host, Joe Rogan.
Well, we've got 1 episode to go in the series of 7, and then we've got to decide where we're going to take this bad boy. So
that's it. How are we going to change the logo?
It's only 2D. Some serious discussions to have.
How am I going to change the logo? It's only 2D. Only so many planes.
So if we have any listeners that are still on this episode at this point, thank you. And please send us some ideas to continue.
Send us some ideas. Yes. Like the podcast. Share it with your mom if she doesn't mind some potty mouth. Go ahead. Rent a plane. Rent an airplane. Here's what I want you to do, all my podcast listeners right now. Go out and rent an airplane. One of those that you can attach one of those banners on the back to. And on that banner, I want you to say, listen to 2 Bald Bastards, episode 6 on Spotify, and then go fly it over the most densely populated spot in your area. It would really help spread the word.
Yeah, we're clearly not trying to be the most polished show out there. We're just going to talk off the cuff and drop a few F-bombs. So I apologize for that today. I get a little bit passionate when I talk about low back.
I don't.
So
I don't care.
So that is the beauty of these two bald men. We'll just speak our minds and rip into some coffee and see what happens. So there you go. We are at the tail end now of episode 6. It's been fun talking about some treatment stuff. And, I think this is an important episode because what we do in treatment is it's well directed by everything that we've done already. And the treatment itself is different in a good way. And, sometimes it's hard to explain that to someone, I think, as well, because the elevator pitch for what we do is not always the easiest thing to explain. Sometimes you get some blank looks. So hopefully amongst all the jokes and all the bullshit that we spin when we do this, hopefully there is a message that comes through about what we're out to try and put out into the world and who we want to help. And ultimately that's what we're doing this for, because whether or not we do a podcast and whether or not we get on the computer and talk once a week, we're still going to be doing the same work and still helping the same people and trying to make the small change in the world that we hope that we can. So, hopefully this helps spread that message a little bit.
I could not have said it any better. I'm just going to shut up.
All right. Well, let's call it. Episode 6 is in the books.
See you guys.
We'll see you all next week.